Morning, everyone. Last year when I came to the Birth and Midwifery Conference the first time, I found myself kind of smiling to myself and realizing I found my tribe. I was so excited, and I thought I'd really like to speak at some stage, and I didn't quite know what I had to offer. And this year when I was approached to speak here, I was really honored, and thank you for letting me stand here today. So talking about cesarean section rates in South Africa, thinking about this, I realized that what I've done in my life is I've stepped out of that system because it wasn't viable for me to be there. But contemplating this talk, it allowed me the time to steep in what is going on in the system. Why do we find ourselves in the system with such high cesarean section rates? Such high cesarean section rates, like Ruth mentioned. The problem is our stats are a little bit difficult to find. South Africa is notorious for keeping very poor quality records and actually capturing data very poorly. So even the stats that we have, I don't think a lot of it's not actually very reliable. But what we have to deal with, what we have is in the state sector, the Western Cape Department of Health, our cesarean section rates are about 19.6, 20%. Then the private stats is something a bit more tricky. The Board of Healthcare Funders states that it's 65%. The largest medical aid scheme in SA says they do 70% Caesars. The Council of Medical Aid Scheme says it's 82%, and then everyone mentions the notorious 90%, that one hospital with a 90% rate. Why is there such a big difference between our state sector and private sector? It's something I feel quite strongly about, and it's something that I think we need to really educate our mothers about. In the public sector, we have very clearly laid out levels of care. Firstly, we start with the MOUs, which is midwife-led care. That is where your low-risk, healthy moms will deliver their babies, the majority of them without ever seeing a doctor. Lucky them. Ideally, they should get one scan so we can ensure that it's an intrauterine pregnancy, and then they can get monitored and managed at that level of care. The moment there's any indication of risk, they should be referred up one level, which is then your primary or secondary level hospitals. At that level, you have medical officers like myself, or you'll have, with the primary level hospitals, you might have a consultant that does outreach, or at the secondary level hospital, there would be a consultant on site. And you can always access consultant advice on the telephone. But if there's anything that can't be handled at that level, only then would a patient get referred on to tertiary level care. So tertiary level care is where there are lots of specialists. That's where our registrars training to become specialists spend their time. And that is where high-risk women go, that is where shit goes wrong. And that is what the doctors see most of the time. So what we have is our specialists that train in this system, training at the tertiary level of care, becoming a specialist, and then stepping into private care in South Africa. In South Africa, we really have a very, very poor midwife. The midwife primary and secondary levels of care are missing. So our young, healthy moms that would in state deliver with the MOUs without ever seeing a doctor go straight to tertiary level care in private. So at this level, they get over-investigated, they get fear-mongered, and they get seen by people that never in their training get to see birth. They don't trust bodies. As doctors, we get taught to trust machines, to trust the clocks, and to trust the scalpels. This really illuminates the importance of appropriate risk stratification, levels of care, and midwife-led care, and the absolute importance of this. And not medicalizing this normal physiological process, but paying attention to risk and treating appropriately. Please understand that when medically indicated, cesarean sections are effective in saving the lives of mothers, but when not, they really do more harm than good. So, like Ruth mentioned earlier, the recommended cesarean section rate between 10 to 15%. Doing less than that, we run into problems. Doing more than that, we really are messing it up. And where we stand at the moment, South Africa is not doing well. So when I was asked to talk about cesarean section rates, I sat and I went to what happens in that system that I was trained with. And the core theme that came through for me is disconnectedness. Disconnection from that which is vital and life-giving. We are a society that don't speak about the two inevitables, birth and death. We've moved those to hospitals behind high walls with visiting hours where the doctors walk. Obviously, the doctors must know what they're talking about because that's what they deal with all the time, right? Is this not all just an appropriate expression of a diseased system? And when I use the word system in this context, I think of the whole system. Look at the planet. Look what we're doing with Mother Nature. Look how we're destroying it. Is the micro level not just expressing the whole? Is it not just the perfect result reflecting our lack of trust and respect in nature and her processes? In our main health stream system, we use the mechanical reductionist approach. In essence, this is disconnection of the systems into different specialties. If there's a problem with your head, you go see a neurologist. If there's a problem with your heart, you go see a cardiologist. With your lungs, a pulmonologist. With your liver, a hepatologist. All of them spending years finding out the pathology of that one system and often forgetting that it's part of the whole. It's the disconnection coming through. Part of the disconnect is expressed in the not feeling. There's no time to be feeling. We need to see patients. Aesthesia, the ability to perceive through the senses. That is our portal into life. We only have these 5 senses to perceive now, to perceive today. Well, you know, the 6th as well, of course. But looking at the word aesthesia and aesthetic and coming to the root word of that, and it's the aesthesing, feeling sensitive and coming into touch with sentient beings. Feeling feelings are uncomfortable. In medicine, you don't have time to be uncomfortable. There are patients to be seen. Feeling pain is painful. It's much more bearable to knock out the pain. Give them an aesthetic. We look at these stats and we wonder why South Africa is such an outlier, with these staggering figures. There's no one to blame for this, but really it must change. This is not first do no harm. And the longer we deny this, the harder it will be to change. Caesars seem to beget more Caesars. So I thought, let me invite you into one night on call. Come with me and I'll take you inside the hospital walls to understand what the doctor's training entail and why we left being the first ones to opt for cesarean sections. Really ask your doctor colleagues what they're going to do when they're pregnant. And the chances are they'll tell you they're having an elective Caesar. I'll take you on call with me for one night and to see where us doctors walk and run and make our decisions from. The decisions to induce and augment, to extract or assist, to cut out or not. These decisions to do the deliveries for these women under our care, our patients. So, it's Thursday afternoon, 3:45, 6 months of my internship. I've spent the whole morning working in the pediatric department looking after neonates with jaundice, toddlers with kwashiorkor, a couple of well infants with bronchiolitis requiring nebs. The rest of the kiddies had sort of run-of-the-mills, pneumonias, gastroenteritis. The little tuberculosis kiddies were restless that day. They're tired of being in the ward. They've been there for more than a week now. One of our colleagues is on leave, another off sick with gastro, of course, we're in peds. And we're still one medical officer short, as the hospital admin hadn't signed a contract after the last interviews. Another day of 3 of us doing 6 people's job. One of these 3 worked night shift the night before and can go home at 12 only, after 28 hours on his feet. It's shit, and that's how it goes these days. One of us covering outpatient departments, 2 of us pushed to get through the ward, seeing patients, then walk through with a consultant to see if we're all in agreement with patient care. Do we need to change any medication? Do we need to refer someone to Tygerberg Hospital, move someone into isolation, or move a child to ICU? Once you're done, you write the discharges, and then you help the doc in OPD. Tonight, my first call for obs and gynae. I've done a 3-month rotation in the department, which was the first of my internship, just following 6-year medical school. I walk upstairs with nervous butterflies in my stomach. I take the handover from the doctors on duty. They're not expecting anyone from the outlying hospitals. We walk past every patient with potential problems and red flag them. The day team leaves, and I'm the only one on for the night. I've ticked the logbook requirements. I've done 10 normal vertex deliveries, 10 vacuum extractions, 10 forceps deliveries. I've cut and sutured episiotomies. I've done a twin normal vaginal delivery and 2 breech deliveries. Fortunately, the specialist we work with was not scalpel happy. I was shown how to do a cesarean section. I assisted in about 30. I was a surgeon in over 21 of them, with a senior assisting me, teaching me and correcting technique while the theatre sisters sigh about the long time it's taking this junior doctor. 1 hour and 15 for the first one, and a young mom with a virgin abdomen. My senior can do this in 20 minutes, skin to skin. Technically, I was considered ready to handle theatre by myself. I was shown the different techniques, how to cut a Caesar. I was taught the step-by-step protocol for massive obstetric hemorrhage on a ward round. I'd never actually at that stage handled any of that myself. It's 5:05 in the afternoon. One of the first phone calls on that night was from one of the neighboring clinics. They have a 26-year-old primigravida at term and active labor that had just crossed the action line. Her waters broke 12 hours prior, clear like all. They're concerned about cephalopelvic disproportion and fetal distress. I accepted immediately and asked them to send her across straight away. I phoned theatre to inform them of the possible Caesar and continued walking to casualty to see what awaits me there. After mentioning all the logbook skills, I must say that most importantly, I've made friends with the midwives in the ward, because without them, you're alone. And that's one of the other things in medicine, you're alone. Alone in antenatal ward with women in preterm labor, gestational hypertension, spontaneous rupture of membranes with concern about early chorioamnionitis. The woman with preeclampsia, looking particularly puffy that day. A woman with antepartum hemorrhage of unknown origin. Alone in postnatal ward, 12 women, somewhere between day 0 and day 2 post-Caesar for various indications. Then there's casualty, where women with spontaneous or illegal abortions can present with bleeding. Women with ectopic pregnancies present in shock from internal bleeding, and they need to be resuscitated with intravenous fluid and stabilized as quickly as possible before taken to theatre. There was no blood bank at the hospital that I trained. We had 4 units of emergency blood, two for emergency center and 2 for labor ward. Once that's finished, it's about a 6-hour wait before the blood arrives from town. Fortunately, I was told jokingly by one of the surgeons one day, all bleeding stops eventually. Just do what you can. It took me a moment to get that if there's no more blood left to bleed, the bleeding stops too. That day in casualty, I was referred a patient, day 4 post-miscarriage with severe sepsis. I quickly did a blood culture and started early intravenous fluid and triple antibiotics for her. An ectopic patient that fortunately the casualty staff had started resussing, she needed to get to theatre. Then there was an older lady with cervical cancer now presented with severe vaginal bleeding. I quickly placed some adrenaline gauze swabs per vaginally, gave her quick words of comfort, write up morphine, booked a bed for her and grabbed surgical consent form for the ectopic patient. We pushed her up to theatre as soon as possible. The surgery was pretty straightforward, and after draining 1.5 liters of blood from her abdomen, I clamped and cut the right fallopian tube and roughly 10-week fetus inside. The left tube looks all right. She might still conceive later. My phone rings. It's labor ward. The patient in bed 3 has a CTG with late D cells. I asked him to get everything ready for theatre. I'll be there in 20 minutes. It's 6:45 now. I wondered what happened to the clinic patient. We're heading for 2 hours after the action line on the partogram. As I walked out of theatre, the ambulance men arrived with her and 2 other patients. None of them discussed with me. I start prepping the first patient for theatre while the lady from the clinic gets onto bed. I stop and follow my gut to her. She's exhausted and very concerned about her baby. I could pick up a faint trace on the CTG with really poor variability and deep D cells. On internal exam, I find thick meconium. I feel 3+ molding and 2+ caput. I phone theatre and tell them that we're coming now. But alas, they tell me the surgeon put a patient with a finger abscess on the table. I phone the matron. We need to open the second theatre. There's no time, she says. We need to get this woman in there, but you have to wait for the surgeon. 25 minutes pass, an eternity. We keep the mom on her left lateral, oxygen on. Everything's ready. In theatre, we put mom to sleep. I cut as fast as possible. The pediatrician is there. She's very experienced, fortunately. The baby is flat and lifeless. The atmosphere in theatre is horrid. I couldn't believe this. My first call, my first alone Caesar. The baby is dying. A nightmare? Or is it a sign? They resus and intubate as soon as possible. Myself and the ped shared a couple of desperate looks while she was busy, and I was dealing with an atonic uterus. Sure, I find so often when I speak about these things, I just can't keep it in, and sure, it's madness. The system is really, sure, it takes its toll. Let me take a moment. I start rubbing it up. We've got oxytocin, thank you, running IV. Miso is given per rectal. I give small aliquots of prostaglandin F2 alpha into the uterus. I stopped shortly before B-Lynch suture and tying off the uterine vessels. We were busy with her for over an hour and a half now, but finally we had hemostasis. We've used the last 3 units of blood, closed up and asked the nurse to ensure that she gets a priority close to the nurse's station. She's a high risk for postpartum hemorrhage. It's 9:30 at night. The pediatrician comes over to speak to the mom about the baby that's settled in ICU. I'm busy prepping the next lady for fetal distress. I rush to theatre and extract a beautiful crying baby. Fucking false positive CTG. It's 12:05. I realized I hadn't peed or taken anything to eat or drink. I walked to ICU, realizing that the baby possibly had severe hypoxic injury. I meet the peds and she tells me the neonat's got hematuria, pee in the blood. The kidneys have also really taken a beating and some of the tissues have actually died. The baby has since had a fit and is doing lip smacking and posturing, all the signs of brain injury, also meconium aspiration, and requiring a lot of respiratory support. I go to the mom in the ward and I put on my brave face and I start trying to explain to this woman that the system has failed her. I start telling her that her baby is most likely going to die. She had so many questions because she arrived in time. She arrived shortly after her ward had broken. She was monitored at the right place. And at the same time, she was sat on for too long. The clinic, when I said the clinic she was referred to, it was literally 200 meters from the hospital, but they were waiting for the ambulance to bring her across to us. The mom was quite confused still after the anesthesia, and I took her with her bed, and we pushed her to ICU. On the way there, we met the mom, the father, and her mother. I explained to them again what's going on. We move her to ICU, and we see this little lifeless baby with all the stickers and pipes, and now we need to explain to them that they're going to be here for a while, and we'll wait. It really is a waiting game at this stage. My phone rings, it's labor ward. Another fetal distress and another non-reassuring CTG. I excuse myself and walk quickly to labor ward. It's the mom with concern about chorioamnionitis, yes, long, late D-cells. We prep for theatre, get hold of the surgeon to assist me and the anaesthetist. The other patient is progressing nicely, the one with the non-reassuring CTG. I get her to mobilize, drink some juice, and tell the staff I'll reassess her as soon as I'm done. 1:45 in the morning. In theatre, she had one previous Caesar, the anatomy is a lot more distorted. I take time to cut carefully, not to injure bowel or bladder. Baba comes out a little flat but responds beautifully to stimulation, a little bit of oxygen. Foul-smelling glycol. IV antibiotics for both of them. 3 o'clock now. I go to the ward, the lady with the non-reassuring CTG delivered, the baby's okay, being sutured for second-degree tears. I get a call from antenatal ward. One of the patients with IV antibiotics drip came out. I go and place another and walk to ICU again. God, how did I get here? I walk to the loo, my phone rings. The puffy, eclamptic lady is fitting. I run there, her drip came out. I find a vein on a moving target. We load it with magnesium sulfate, the fit stopped, in recovery position. Baby's doing okay. On her bloods, liver enzymes and platelets are borderline but fine. We book a theatre, we stabilize her, we move her, we take the baby out. Caesar's all right, another virgin abdomen. The baby is okay. We struggle a bit to stop the bleeding, but we manage. From theatre, I admit her to ICU, and she'll be there for 24 hours on mag self. It's 7 o'clock now. My shift's nearly done. My mouth is a desert. I still hadn't peed. I feel broken. I start crying. As one of the consultants walked into ICU, I stood with him next to the baby's bed, and he spoke. And he listened, and it really is so seldom that you come across some of the seniors that take the time to stop and listen, because on that day, I really just needed someone to hear me. And he did, and that's fantastic. I walk back to labor ward, and I hand over the night. And one of the team members asked me, how was your night? And I said, I kind of smiled, and I said, it was okay, because it's just another night. She says to me, it's not your fault, it's just your turn. So I make my way downstairs to the ward rounds in P's ward. I still have to go till 12 o'clock. I'll be on call again on Friday night, starting Friday 7 o'clock in the morning through to 11 o'clock Saturday, and then Sunday starting 7 o'clock in the morning through to Monday. In 2 years of internship,
there were 5 months that I didn't sleep. And this is the system. So you say, okay, why am I standing here telling you my soppy story? This is the system. This is where the disconnectedness comes from. If you have to feel every single time that you're on call, I don't know if we have the capacity to feel this way. If this is the system that we're raising our doctors in, how do we expect them to feel? How do we expect them to connect? And I realized as Caitlyn was speaking that disconnectedness means brokenness. And I guess where we start is by having these conversations. And I think the healing starts right here today. Thank you.